newer improvements expected in TB diagnosis and treatment will be affordable with current budgets. The future of TB control must move beyond the self-imposed budget limitations of a $2 test and a 2-penny pill. Our budgets and our strategies are tied to possibly unrealistically and uniquely inexpensive tests and treatments. So when that supply chain is interrupted, no one can really afford a plan B, at least not in Hawaii. Instead, we're sort of left to shut down operations, and that's not really a very good plan B. So, it's not been like the plagues of locusts followed by the frogs, but these two concurrent shortages of PPD solution and INH have taught us the value of redundant systems for ordering in Hawaii, of new flexibility needed for our TB laws in Hawaii, and they've revealed the resource vulnerabilities that are inherent in our current TB strategies. All of these must be addressed in Hawaii before we continue down that road towards eventual TB elimination. Okay, that's it for me, and I'd like to thank Derek Felix for some of the data included in this presentation.
Great. Thank you so much, Dick, for an excellent presentation. And rather than go to polling questions now, I'm going to introduce Margaret Oxtoby, another CDC medical officer from New York State TB controller. So, Margaret, you're on.
Good afternoon. Can you hear me?
Yes, very well.
Great. Well, I think that Dick presented some very broad issues, and John Workington also provided more of a national perspective and also Tennessee-specific experience. So I'll focus just on anything similar or different in the New York response, and we have shared the concern about the shortage of PPD solution. In contrast to Hawaii that you just heard really basically has a very centralized program where most of the testing is done by the health department. It's not that way in the New York State area. We have no central stockpile in the state, and each local health department, each healthcare institution, specific agency, and as well as the practices seeing patients are responsible for ordering their own supplies and conducting their own TB testing. And I should mention that there's a very strong local health department system in New York where most of the responsibility for the day-to-day oversight of TB is at the local health department level. And just to show you that we have the New York City Health Department, which it comprises the 5 boroughs of New York City, and then 57 other counties in the state, each of which has their own local health jurisdiction. And again, that's where most of the TB oversight is done, is at that local level. And you can see by the colors that most of the cases in New York are in New York City area. We had about 900 cases last year, and a little over 2/3 were in the city. A lot of the others around that city area, but really throughout the state and at different times. And our case rate, everyone's familiar with the fact that New York, not just New York City, but the rest of the state as well, was impacted very greatly in the late 80s, early 90s. We had extensive outbreaks with hundreds of cases in a year in prisons. We had homeless shelters, other congregate settings with rapid spread of TB, and including infection of healthcare workers and other providers. So part of the response was strengthening testing programs in these settings. And so we have gone down from 4,500 cases in 1992 very rapidly to about 1,400 10 years later, and with a much slower decline since then. So I'm not going to go into all the details of every single setting, and one of the things that if there are some people on the line that are from New York State that want to ask me some questions, it's better probably to ask them separately to us or to the regional staff in our program, and we can definitely get you any information if something's not clear. But as we know, both employees and volunteers in clinical settings, in a variety of different settings, do have required pre-employment and annual TB assessments. And that is not only the test itself, it is also the risk, the history, the symptom review, et cetera. But it does involve either a tuberculin skin test or within the past 5 to 6 years, depending on the setting, we have passed regulations that allow use of IGRAs, either the quantiferon or the T-spot, in those for those same individuals. And again, because sometimes the health department organization, different components came together at different times, not all of the regulations are exactly concordant from one to the other, but the spirit is similar, making sure that there's an adequate baseline, including if a TST, two-step testing, and then serial testing, preferably with the same antigen, but that's not required. In terms of residents, we try to limit residents or clients or school kids or other settings where anything is required, but as people have mentioned, long-term care facilities, nursing home patients are one group that is required to be assessed on entry. We do not have any follow-up routine. There is no need for any periodic testing in the absence of symptoms. And we also collaborate with a variety of other agencies that we do not directly oversee their programs, but provide technical assistance or opinions or support for their guidance to try to limit some of the overtesting. So we had informal reports from certain areas, particularly in some of our lower incidence areas of the state, of some difficulty getting Tubersol, but didn't have significant problems until early March. And we did put out a health advisory that gave that emphasized, along with national guidance, the prioritization for persons who are contacts, those evaluated for suspect active TB at increased risk for TB due to medical conditions, or recently arrived persons. And we did suggest that they could defer the serial testing until the solution was again available, while continuing to make efforts to order it. We have had the problem in our state of clusters of tuberculin skin test conversions, which is a reportable condition. A cluster, meaning a potential outbreak, is reportable to us in settings where people have changed from one solution to the other. We wanted to avoid that, given that it appeared to be a short-term problem, and so we allowed people to develop policies at a local level where they could bring back employees required to be tested after the shortage was relieved. We then, earlier this month, put out another update emphasizing that there still was a need to comply with the regulations for testing pre-employment, and that could be done, as we've stated before, with PPDs or with IGRAs, but there was no waiver or anything of that regulation. So we wanted to emphasize that, and shared further updates as we received them in terms of availability of the solutions. So we certainly are hopeful that it will be resolved, and we again are using this as an opportunity to look further at who's getting tested, and it has brought us into contact with a variety of different partners who we had not worked with as directly just recently around these issues. So, thank you.
Great. Thank you, Margaret, for another excellent presentation. So I think we've heard perspectives from a couple of our state programs. We have several more polling questions, and then we will take questions from the group. So why don't we go to the next polling question, Donna? Since the PPD shortage, have you prioritized indications for TST? In other words, prioritize patients based on their risk status, potentially, for receiving skin testing?
And Sanjay, this is Dave. We're getting so many questions that we want to start the questions. So we're going to do a couple of polling questions, but What I'd like to do, if it's okay, is let Donna just quickly tell everybody how they can ask their questions once we finish
Okay.
the next three. We're going to do just 3 polling questions, and then we can come back to them later.
Okay,
Donna, do
sounds
you want to
good.
go over how to ask questions?
That's fine. Hi, everybody. So if you were only able to join by phone because we did reach our maximum seating capacity in our webinar, you can press the *7 to unmute your phone and ask a question, and then *6 to mute. Please don't do that yet. We are still going to do a few polling questions, but we do want to give everybody an opportunity to ask questions, so you can do it that way. Those of you that have been asking questions in the chat and the Q&A, we have been watching those and collecting them, and we will try to address all of those before the end of this session. All right, back to you, Sundari.
Okay. All right, so good. It looks like we have about 2/3, 1/3 in terms of prioritized indications for TST. Let's take the next polling question. If you have a prioritization scheme, what procedures have you implemented? And you can answer all that apply. Have you stopped all LCBI testing? Stopped routine LCBI testing, or just used TST in high priority testing, like, for example, contact investigation?
And I think you can see here, Sundari, that it looks like it's very interesting that we're seeing a couple different things. One is that we're seeing that really only using skin testing for those high priority testing, which I think we'll go into in a couple minutes, and also a lot of stopping of routine LCBI testing. I think Dick's presentation really, I think, emphasized some of the obstacles that can occur, but the importance of being able to do that, especially in a time where there is a shortage.
Right, exactly. It looks like the majority, 80%, are only using TST in high priority testing situations now. Okay, let's go to the next question. If you've postponed LTBI testing in this situation, are you planning on resuming testing with the TST once the shortage is resolved? Yes, as soon as the TST antigens are available. Yes, that next testing cycle. No, we've switched to IGRAs. Yes, we're testing with IGRA, but we'll retest with TST once again, or other. And I think what we could have asked maybe is whether they would continue to prioritize individuals who are high risk, having learned from this opportunity. I don't know, we didn't ask that, but looks like the majority of people would resume testing. And again, we don't know if you'll resume at the same level we're doing before or not, but you'll resume. Okay. All right, what do you think? Should we stop there, Dave, or did you want to do one or two more?
I think we're getting a lot of interesting chats and questions being posed to it. And I think this is a time, because we want to make sure we have plenty of time to answer questions and ask questions, because, that's one great thing about the TB community. We're a small TB community, and it's always nice to be able to share what our experiences are. So, if I can, let me start with the questions that we're getting on the chat. So the first question we're getting is, can we specify exactly what caused the shortage? And at least personally, and I turn to John too, but in my conversations with the company, at least Sanofi, it is not clear, and we have not gotten, at least I have not gotten a clear answer of what exactly caused the shortage. John, do you agree, or?
Dave, I agree.
Yeah, so I mean, I think at this point, asking what caused the shortage, we don't have an answer, and I have to be honest with you, I'm not so sure it really matters. I think the question is, what can we do, and how do we adjust as a community? So, I just want to put that out there.
Right.
And then, the other question we're getting a lot of is, what to do with, like, in hospitals and facilities where skin testing, or at least LTBI testing, is required on an annual basis. And I think the first thing we would say is that it's important to assess, is that still necessary, as the CDC guidelines pretty much point out that, the need to do testing and how often is really based on the risk assessment of your facility. And that should be adjusted that way. But there are a number of facilities right now that there is not enough there's not enough antigen. So I do know that many have actually postponed at this point, their testing, and they're waiting for the antigen to come back, and we'll resume it at a later date. I'm seeing some discussion. I wonder how the rest of you guys feel about some of the hospitals that think about switching to IGRA, but I think you'd agree it's a little difficult to go from skin testing to IGRA, because you don't want to keep going back and forth. Sundari, do you agree with that, or?
Yeah, I think absolutely, and I'm going to have John speak to that as the author of the MMWR as to why that might be a problem to go from one test to another during serial testing.
Right. So this is fairly subtle, but I'll talk about serial testing and what happens when you switch around between the testing methods. Of course, there are the administrative problems that you don't just suddenly one day buy a different product and change all the processes. You do have to retrain people. You have to put different kinds of tracking systems into place. Those little nitty-gritty problems become big nitty-gritty problems if you're dealing with thousands of employees in a major hospital. And even in a smaller setting, you know, when you don't have that many personnel to work on infection control, it's still a big deal to switch, certainly between the skin test and the blood test, but also even in terms of setting up the ordering practices to switch between two products in the same category. And then there's the fact that even though all of these testing methods and products are comparable in cross-sectional studies, on the individual basis, they behave a little bit differently. So here's an example. If you had 1,000 people and you test them all with Aplasol and you test them all with Tubrsol at the same time, you might find that you get 5 reactions with Tubrsol and 4 reactions with Aplasol, very close numbers, but they won't be the same 5 and the same 4 that are reacting. So whenever you switch between products and you're testing personnel over and over, you get some weird fluctuations of results that you have to deal with. Then there's the added fact that we still don't know that much about how well do IGRAs behave in serial testing programs. Certainly with TBSC and Task Order 18, which still doesn't have its results published yet, there were some very disconcerting discoveries about the stability of results with IGRAs, both the quantiferon and the T-spot. So in switching, it raises a lot more problems than perhaps you'd get if you were just to defer testing for a while.